Hello, everyone. It's my pleasure to welcome you to today's Covetent webinar, Living Rapid Reviews, Methods for Dealing with Study Results with Limited Relevance to Current Context. We're excited to have two great speakers with us here today, but before we begin, I wanted to note that there will be an opportunity for questions and answers later. You can use the chat box to ask your questions or share comments during the presentations. Also, if you have any feedback after today's event, please email us at covidend@mcmaster.ca. Joining us for today's webinar are Maureen Dobbins and Sarah Neal-Stramko. As a very brief introduction, Maureen is a co-chair of Covident's Engaging Working Group and the scientific director of the National Collaborating Center for Methods and Tools. Sarah is an assistant professor in the Department of Health Research Methods, Evidence and Impact at McMaster University, and a knowledge translation advisor also with NCCMT. Please welcome Maureen and Sarah.
Thanks so much, Steve, and welcome. And we're so glad that you were able to join us for this webinar today. So I'll just start off with a very brief introduction to Covident, and then we'll move into talking about the rapid reviews that we've been doing at NCCMT, as well as what we've been grappling with respect to when data comes out on studies from early in the pandemic that may not be relevant to the question that we're dealing with. So we're just going to tell you a little bit about how we're dealing with that, and would really like to hear your thoughts about that as well. So next slide, please. So what is Covident? So the intent has always been that it is a time-limited network that came together in response to the pandemic to really help those who are supporting decision makers about COVID-19 to find and use the best available evidence. That's what we call the demand side. And then also to help researchers to avoid waste by reducing duplication in evidence syntheses and to better coordinate evidence syntheses, technology assessments, and guidelines. And we refer to that as the evidence supply side. There are over 50 partners that joined Covident, including world-leading evidence synthesis, technology assessment, and guideline groups. And we cover the full spectrum of pandemic responses, for example, public health measures, clinical management, health systems arrangements, and economic and social responses, as well as representatives from both high-income and low and middle-income countries. Next slide, please. This just gives you a really quick snapshot of the logos of the partners with Covident. And if we just go to the next slide, if you would like to know more about Covident, there is a website. You can visit the website where there is a wealth of information, including an inventory of best evidence syntheses for the 4 topic areas of public health measures, clinical management, health systems arrangement, and the economic and social responses. I've also been involved in doing horizon scanning to understand what the issues will be in the short and long term, and the results of those are you can also access through the website. We do have a community, an online community of practice for those that are supporting decision making. That is sustained by the Engaging Working Group that myself and Lawrence Langer co-chair. We currently have more than 300 members on the listserv. You see the website there, or the link that would allow you to sign up for the listserv. And generally, we organize different topics for 2 to 3 weeks in a month that generally relate to the different kinds of methods or knowledge translation, ways to support those who are supporting decision makers. So that has been up and running for about 1 year now. I think we made our first post around early July last year, and would love to have you participate if that is of interest to you. There's also, you can find out about the Living Hub of COVID-19 knowledge hubs at the Covident website. You also have listed here the email address as well as our Twitter handle. And next slide. And just around acknowledgement, so Covetent really was made possible through a variety of funding mechanisms. The first from the Government of Ontario through a grant to the Rapid Improvement Support and Exchange, what is referred to as RISE. And so early in the pandemic, that funding was really directed towards COVID and supported the creation of Covetent. As well as the National Institute of Health Research in the UK. There were also some individual donors through the Center for Effective Altruism and Fidelity Charitable in the US and other private individual donors. And then starting in December, a grant from the Canadian Institute from Health Research here in Canada has also supported Covetent as well. So that's just a little bit about Covetent, and now I will move into talking about today's topic, which is rapid reviews and studies with data that is no longer relevant to the current context. And it will, Dr. Stramko and myself will lead that. I will take you through a few of the slides telling you a bit about the National Collaborating Center and really how we ended up doing rapid reviews, and Sarah will take you through in more detail what we're actually doing, and then I'll finish off with a few more slides about a little bit about the impact that our work has had. So next slide. So if you're unfamiliar, there are actually 6 national collaborating centers in Canada. We emerged from SARS, so a number of the inquiries that were done following SARS indicated that there were some limitations in our public health network across the country. And so these 6 centers that all have addressed different specific topic areas were created, and we've all been up and running since about 2006, 2007. And if I just go quickly across our country, starting on the West Coast, on the left side of your slide, we have 2 of the NCCs. One is located in Vancouver, at the which is called the National Collaborating Center for Environmental Health, and they focus on the science and the knowledge translation of best available evidence in environmental health, as well as helping to build capacity in public health to be able to use the evidence related to environmental health. We also have above that, located in Prince George, British Columbia, the National Collaborating Center for Indigenous Health. And they really are our leaders in helping to support the use of best available knowledges related to Indigenous health and in working with those who work with Indigenous populations. As we move east, we move to Winnipeg, located in Manitoba, and that's where we have the National Collaborating Center for Infectious Diseases. And they work on a variety of projects around embedding evidence and science into infectious disease control. They do a number of things around mathematical modeling, as well as in communicating information about infectious diseases. Then we come to us. We're next located in Hamilton at McMaster University, and our goal is really around supporting knowledge, skill, and development across all public health professionals to use best available evidence in their decision making. We also have, continuing to move east into Quebec, we have the National Collaborating Center for Healthy Public Policy, which is really helping to build knowledge, skill, and capacity around the public health sector's capacity to not only use healthy public policy, but to advocate for healthy public policy. And then we have on the East Coast in Antigonish, Nova Scotia, the National Collaborating Center for the Determinants of Health, which is really focused on everything around embedding within decision making the issues around the structural determinants of health and building capacity to ensure that policies and programs embed that lens of reducing inequities into program planning. So if we just move to the next slide, just a little bit more about the NCCMT is our short name. Some of our products and services, we really use a comprehensive approach to build knowledge, skill, and capacity across the workforce in public health in Canada. We have a variety of registries. One listed here is around methods and tools for evidence-informed decision-making. We also have a suite of online learning opportunities such as online learning modules that one can use to build capacity. We do a great variety of workshops on anything related to any evidence-informed decision-making. They used to be primarily in person. Now we've been experimenting and had some really great progress in offering virtual workshops during the pandemic. We also have some other knowledge repositories. One listed here is Public Health Plus. There's another one called Health Evidence, which is compiling the public health evidence on effective interventions for public health. Video series, we have one that's related to understanding research evidence, which are short videos about different types of statistics and what we see in the public health literature. And then, of course, we're also here to help connect decision makers from across the country so that they can work together and collaborate on their knowledge. Next slide. So as the pandemic hit, we were very much involved in helping to build capacity in the public health workforce to use evidence, to find evidence, to appraise evidence, to inform decision making. And very quickly we knew that the audience that we generally worked with would be fully deployed into the COVID response. As we were thinking about, well, what would we do then, given we wouldn't be able to do our regular work, we started to receive requests from that target audience to help them with conducting searches for an evidence synthesis they were going to take on related to COVID in their health unit. Or we were thinking we might be able to support the critical appraisal of the evidence syntheses that folks were telling us that they were going to be engaging in. But very quickly after that, pretty much all of those staff were deployed to other activities related to COVID. And so while the need for synthesizing evidence to support public health decision-making was great, the capacity within the sector to quickly mobilize to synthesize this growing body of evidence was very quickly depleted, and there really wasn't, there weren't many that were there that could take on that work. So the capacity was really small. And so then we did a very significant pivot to say we would reallocate the majority of our funding towards supporting public health, and opened ourselves up really to business to say we will take your questions and we will conduct rapid reviews in days in order to help support that decision making. Slide. And so really that's, I've already said all of this, getting ahead of myself, but really our goal was very much to respond as quickly as possible to the needs of decision makers across the country. And that could be at any level, from our federal policymakers to the local level that we're implementing various responses to COVID. Next slide. And I will hand it now over to Sarah, who will take you through in more detail the process that we use for a rapid review.
Great, thanks, Maureen. So I'm going to highlight the basic steps that we use for our rapid evidence service across all reviews, and then we'll finish up with a little bit of a discussion about some of the things we've been grappling with as the evidence evolves and as we move into different phases of the pandemic, and how do we deal with questions about the relevance of evidence from different time periods. So in terms of our rapid evidence service, we do follow the modified steps from the NCCMT's Rapid Review Guidebook. So this guidebook was created and published prior to COVID, so some of the steps certainly needed to be modified for the speed at which the questions needed to be answered in response to the COVID pandemic. So we prioritize questions from requests that we receive from a number of decision makers and follow sort of a relay race within our team from defining the question, searching for research evidence, critically appraising the evidence, synthesizing evidence, and then identifying any applicability and transferability issues within the local context, depending on the decision maker that may be requesting this rapid review. We aim to complete our reviews within 5 to 10 business days. Earlier in the pandemic, we were completing closer to that 5-day mark, and now 10 days is still a push, and sometimes our reviews now are getting much longer as the scope of the evidence is much larger than it was earlier on. So our team, this list does make our team look a lot larger than it actually is because not all of the staff are full-time allocated to this work, but our team includes our scientific director, Maureen Dobbins, who you've met this morning, an operational lead who helps us organize staff time and task management, scientific lead, which is myself, and so managing some of the decisions around the methodology behind the rapid reviews. We have 3 to 4 different rapid review leads on any given topic. So each person leads one specific topic, and so they're responsible for sort of quarterbacking the entire review and writing the main executive summary and key findings. We have a coordinator who works across to make sure all of the pieces get accomplished, that one set of tasks is passed on to the next person, sort of in that relay. We have a search lead who's become very familiar with all of the nuances of the COVID-specific databases and how to search for COVID-specific evidence in our traditional databases. We have 1 to 2 staff who support the searching for any given question, and then 3 to 4 staff who are providing other support for summarizing evidence from individual studies and critically appraising individual studies. So our team receives questions from federal, provincial, and territorial, as well as local organizations, and we have taken questions from international organizations as well. Earlier on in the pandemic, we were receiving them directly to the NCCMT through our own networks, but as we've become involved in Covetent, we do take questions across Canada from the Covetent Canada network. So we have a weekly team meeting with our team to assess the progress of our current reviews and our capacity to start new reviews. So as I mentioned, we do have a small team and a number of other work plans that are ongoing. This is not our team's full-time work, so we do have to assess what our capacity is on any given week. In terms of how we prioritize which questions we'll take on, our key question or key concern really is making sure that we avoid duplication, and that our ability to do that has really been enhanced with our involvement in Covetent, being able to connect with a number of other synthesis groups across Canada and internationally in real time to make sure there aren't other groups that are taking on the same question at the same time or have finished that question recently, so we can build upon what work's already been completed. We know that earlier on early in the pandemic there were lots of duplication. So that's really our key right now before we start anything, is making sure there's not another team that's working on this. We really look at the urgency and relevance of the question to the Canadian context in terms of whether we'll take this question on now or whether it's something that can be worked on in the coming weeks, and the speed at which, the time frame in which we might work on the question. We really try to consider our content expertise in-house to address the question. So as Maureen's highlighted at the National Collaborating Centre for Methods and Tools, our main expertise is really in the realm of public health. So some of the questions about more laboratory-based studies or testing, we come really outside of our comfort in answering those without a methodological expert or content area expert in that area. And also the availability of useful or usable evidence. So sometimes we have received questions where there just really isn't much evidence to synthesize, and in those we may prioritize questions like that lower in our list. So our first step, of course, is formulating the question, the answerable question for our rapid review, similar to any systematic or rapid review that you might be conducting. So we use the PICO or PS format where possible, although that's not always the case. And really, we aim to collaborate with the requester to really understand what is the key question, what is the key information that they're looking to get out of the rapid review. And that helps us to define our inclusion-exclusion criteria. So differently from how we may approach a traditional systematic review from a research lens, we really want to work with the collaborators. Is there a specific decision that this rapid review will be helping to inform to understand what's the most relevant and useful evidence at the current time to answer the question appropriately. And so you'll see an example here on the right side of the screen, how we framed a review on schools and daycares. So what is the specific role of schools and daycares in COVID-19 transmission is a key question. And then we use that to outline our inclusion-exclusion criteria. So once we have identified our criteria, of course, we move on to searching. So we first outline our search strategy. On our team, we do predominantly search the COVID-19 databases. We have shifted a little bit to searching Medline rather than Lit COVID, for example, although earlier on we were searching Lit COVID. But we just find that has worked well for our team. There are some exceptions for questions where we do need to look outside of the context of the COVID literature. For example, we did a review on reasons for vaccine confidence and uptake, and we did include non-COVID literature. So of course it was important to search our traditional databases for that type of evidence. We do search for English language studies, although if we find a study that is not in English, we may try to include it if we have capacity. We do have a little bit of French language capacity on our team. So if they're identified and determined to be eligible from an English language abstract, for example, we may include it. We include both peer-reviewed and preprint sources. And depending on the question, we may search for gray literature outside of our traditional academic databases or look for jurisdictional data if that's really key to being able to answer the question. So an example of that is we took on a question early on about the impact of the pandemic and associated public health restrictions on opioid use and opioid use associated harms in the context of Canada. And we found little to no published studies. So we did actually go and look for jurisdictional data on any updated surveillance data that had been published in different jurisdictions across Canada, because that was really the best way to be able to answer the question. We try to prioritize including syntheses before single studies. So if we find a high quality synthesis and we determine high quality is including critical appraisal of the single studies and describing a comprehensive search strategy. If we identify a high quality or reasonable quality synthesis, then we may include that synthesis and only include newer single studies published after that, the search date of that synthesis, rather than redoing. So again, that's just one of the steps that we take in our rapid reviews to streamline the approach and keep the number of studies more feasible to complete in a given time frame. Here's just a really quick overview of the databases that we search. So the COVID-specific databases are listed here. Our more general databases, the Guidelines International Network, TRIP, the medRxiv preprint server, and Prospero, which helps us to identify any other reviews that are either ongoing or recently completed. And then we do have some key websites or repositories that we do look for, particularly in the Canadian context, to help us identify any recent high quality syntheses that may have been conducted or are underway. Then we move on to screening. So we do use a single reviewer for title and abstract screening. So that's again one of the steps that's sort of shortcutted or streamlined in a rapid review compared to our traditional systematic review. We use Distiller software to screen at the title and abstract level, and that's really helpful for our team because we're able to use the DAISY function, which is an AI function that ranks the potentially eligible studies upfront, which helps us to sort of identify the most likely to be eligible early on and helps us to move forward with some data extraction before all of the screening may be complete. It also has a function that allows you to review studies that you may have inadvertently excluded. So with the AI function thinks that you've accidentally excluded, it provides a list of those. So it's just another way that we can very quickly double check if we've potentially excluded studies that might be eligible. Certainly not as comprehensive as double in duplicate title and abstract screening, but it's one of the ways that we feel a little bit more confident in our process. And then, of course, some of you who are working in syntheses in COVID may know some of the COVID-specific databases don't have great export functions, particularly in terms of the websites and repositories that we're looking through. We do have to manually screen those online, and we track those in Excel. And then we also use a single reviewer for full text screening, but that is double-checked during the summary rating phase. In terms of our data extraction, all data is extracted by one reviewer, one of our support staff, and checked by the rapid review lead. We always extract key information on the study design, the population, the setting, and then a summary of the key findings that are relevant to our research question. We include a rating of the quality of the included studies based on our critical appraisal, which I'll talk about in a minute. And then some, depending on the question, there could be other specific data that's extracted as needed. So our team feels that critical appraisal is really, really important in the context of COVID. If we look at sort of our pre-COVID, the steps that could be streamlined or skipped in terms of a rapid review, skipping critical appraisal could be one of them. But we thought in the context of COVID, it was particularly important to keep this step in place. So some data that came out at the end of 2020 showed that preprints were accounting for about 40% of all of the English language COVID work that was available. That's likely changed a little bit since then, but given that the bulk of the studies that were being included hadn't undergone peer review, we felt that basic critical appraisal of the methods was really, really important. Early on, we saw fewer synthesis groups that were appraising the evidence, most likely due to the speed that these questions were being asked and the answers that were being needed. But we felt that taking that extra step was really important to highlight the most trustworthy findings. So as we found a large number of studies, sometimes with conflicting information, we thought critical appraisal was really one of the ways that we could help to identify and pull forward which ones were the most trustworthy findings that we could sort of base our synthesis on. So all of our critical appraisal is completed by one reviewer and verified by a second. We resolve all conflicts through a discussion or input from a rapid review lead as we need to. We use a variety of tools depending on the study design. So for systematic reviews, we use the AmStar1 tool. For guidelines, we use the Agree2 tool. And then for all other study designs, we use the Joanna Briggs Institute checklists. Rather than reporting in terms of the rapid review, to keep it concise for decision makers, rather than reporting the full results of the critical appraisal checklist, we rate each as either strong, moderate, or low quality based on the total score of each. But we always have those ratings available, full ratings available upon request for anyone who's interested in those. Early in the pandemic, as we started our rapid evidence service, we were just including critical appraisal of the single studies, but we started to become concerned as we move forward that we were almost artificially highlighting, we were being more generous with our ratings of the overall quality of the evidence base than we would like to be, as we were including a lot of studies that were case reports or case series. So we know that even a high quality or really well done and well reported case report doesn't give us a lot of confidence in the findings overall compared to a well done observational study or a randomized controlled trial. So we started to incorporate grade just to be able to answer the question, how likely are the findings to change with more evidence? So we use the grade approach to assess the overall certainty of findings over and above just the quality of the individual studies that are included. So it allows us to incorporate risk of bias, of course, but inconsistency of the effects, the indirectness of the interventions or outcomes, any imprecision in the effect estimate, publication bias, magnitude of the effect, dose response, and accounting for confounding. So grade has really given us a lot more confidence in being able to state the certainty of the findings overall as very low, low, moderate, or strong. And we found that incorporating the grade step does not add a huge amount of time to the overall process and has really, I think, increased the quality of our summary statements. And then our final product looks a lot like this. So you'll see an example of a front page on the right-hand side of your screen. So we list the question. It's followed by an executive summary, which is very brief and looks quite a bit different than what a traditional rapid review would have looked like in pre-COVID times. Key findings and the certainty of evidence from our grade statement is up front, usually only a couple of bullet points depending on what our key outcomes are. If it's an update to a previous rapid review, we highlight what has changed in that update and then list an overview of the evidence and any knowledge gaps that were identified. And this usually takes about a page, and we don't have any other formal write-up in terms of results or discussion within the document. So following the executive summary, we highlight the main methods that we use and then the results from the single studies in a table format. But unlike a traditional rapid review, we don't have sort of the traditional introduction, methods, results, and discussion write-up. So really succinct, high-level summary at the beginning of our review. And I've gotten ahead of myself as well. So this is what our executive summary looks like. Very high-level background, 1 to 2 paragraphs to outline what the purpose of the review is, our key points, and then for any updates, of course, what has changed, whether it be inclusion of new studies, any change to our eligibility criteria, which we'll talk a little bit more about in a moment. In terms of our summary of findings, we do include the summary of findings table in accordance with grade. So for each outcome, we list the study design, number of studies included, and their overall certainty of evidence. At the bottom of the table, the reasons for upgrading or downgrading are provided for transparency. And so this is an example of a quantitative summary of findings table, but we've also done a number of reviews now that have included qualitative evidence, so it looks a little bit different as we use the grade CIRQUAL approach. So again, the key finding from the qualitative studies, the number of studies that contribute to that finding, the confidence in the evidence, and then an explanation of that assessment. So looking a little bit different for qualitative studies. So one of the things that we've been struggling with over the last number of months within our team is the evolving context of the pandemic, and how do we continue to publish high quality, rigorous, comprehensive rapid reviews in a reasonable time frame that are synthesizing evidence that's most applicable for decision makers right now. So one example where this has come out frequently over the course of the number of months is our review, Living Rapid Review on Schools and Daycares. So the first review we published on this topic was back in May of 2020. And at that time, there was really limited evidence on the role of schools or daycares for obvious reasons. Schools were closed down for most of the world when the pandemic was declared in March of 2020. So the studies that were being published were case reports prior to school shutdowns of a student had come back from travel, had gone into a school setting with either symptomatic or asymptomatic COVID. This is the number of cases that came out of it. As the pandemic evolved and as schools started to reopen in different jurisdictions, starting with Australia and Israel and other locations around the world, we were starting to see more comprehensive data, and we were able to get a better picture of what it was looking like, more rigorous designs. But one of the things that we struggled with was a huge increase in the number of studies from May 2020 moving till now, July of 2020, and how do we continue to include those on a regular basis? Knowing that some of the studies that were published or data that have been collected in February or March of 2020, at the time where there was really limited understanding of the mechanisms of transmission of COVID, of the role of infection prevention and control measures. So certainly in February of 2020, as those students were coming back to school with COVID, there were certainly no infection prevention and control measures in place. There was no contact tracing, very limited contact tracing available. So how applicable are findings from that evidence to our current context now? So we made the decision with our schools and daycares to review to adjust our inclusion and exclusion criteria to more closely align with their current context. So we did have a number of these changes to the criteria that occurred over a number of different iterations of our Living Rapid Review. We shifted to a preference towards less so around the specific design that was used, but the type of data or outcomes that were reported. So we began to exclude any studies that only reported on an absolute number of cases or overall prevalence without any indication of secondary attack rates or discussion of likelihood of transmission within the schools. We also excluded studies that described the risk of COVID or COVID-19 mortality between teachers and people working in other occupations, or students or parents attending school versus those not attending school, because really those studies had a lot of problems with confounding, and it was comparing different jurisdictions in that way, or pre-school reopening and post-school reopening really wasn't helping to answer the question of transmission within the school setting. We also made the decision to exclude any studies where the data was collected prior to July 2020, either during or following that first wave of lockdown. Again, for the reasons I highlighted earlier, when there was really limited understanding of disease, available of personal protective equipment, recommendations for mask wearing were not in place, access to testing was not where it is in most countries around the world now. So the applicability or the likelihood of transmission within the school setting when no measures at all were in place was not necessarily relevant to our current context where there are measures in place and availability of testing and mask wearing is encouraged both in schools and out of schools. So we made those decisions. One of the things that we feel is really important as we adjusted these criteria was being really transparent about that. So it's highlighted both in the what has changed section of our executive summary, we include that in the methods, and we include a full list of the studies that we had previously included or that would have been included with our initial criteria that were excluded in future iterations of our living review, and those are all available in a supplementary appendix. So studies that were excluded because of the time period. We have about 40 of those studies on top of the 73 single studies that are included at this point in our living review, and studies that were excluded based on those methodological criteria. We have 38 studies now on top of the 73. So by adding this extra criteria in, we reduce the number of included studies by about half, which makes it a lot more feasible for our team to complete reviews on the updates to the review on an ongoing basis, and also just make sure that the evidence that we're including in our rapid reviews is most relevant to the current context. So we've seen this most in our schools and daycares review, but it's certainly we're grappling with this in a number of different reviews as we move forward. How do we adequately synthesize international evidence in evolving contexts so we know that vaccine coverage and variability in vaccine coverage across different countries is changing transmission or a number of the outcomes that we may be looking at across a number of different questions. As variants of concern take over and are different in different jurisdictions and arrive in different locations at different times, how do we grapple with that and reconcile that as we're synthesizing evidence from a number of different locations and collected over a number of different time periods? Rates of community transmission. So how do we incorporate that into our synthesis? So these are the things that we're still struggling with on an ongoing basis, and certainly we would love to hear from other teams with how they consider these different factors in their reviews, especially living reviews, as things are progressing. And I'll turn it back over to Maureen for a little bit about our dissemination plans.
Sarah. I don't know, we might want to go back to the previous slide. What I thought we could do is maybe address a few of the questions that are in the chat before we move on to this other part. But so sure. I can read those out and then get your thoughts on them. So I'll just start with the most recent one, which came from Simon. And Simon is just looking for some clarity around the excluding data that was comparing transmission from those in school and outside the school. And just wanted to understand that a little bit better, why we made those decisions. He's thinking that would have been actually really important information to discuss.
Yeah, great question. So just to clarify, we excluded studies that compared, for example, rates of COVID or COVID mortality in teachers compared to another occupation. Where there was no indication that the transmission, that either occupational groups had actually contracted the disease within occupational settings, no other. So, studies looking at, from May to December, teachers had lower risk or higher risk of COVID versus people working in hospitals. So we just felt like that actually wasn't able to answer the question about the roles of schools when we're comparing just different occupational groups. But certainly ones that looked at before and after lockdowns, those studies we did continue to include those. Does that answer the question?
So we might hear back from that. And then there's another question from Christian. He has a couple of questions. So the first one is there any cases where the scope of the review and the eligibility criteria might change over time, so updates might be answering slightly different questions?
Yeah, I think that's a great point. I'm trying to think, Maureen, if we have an example where we have tweaked some of our criteria Actually, there's one example that we can think of where we actually stopped updating in terms of long-term care. We had done a couple of updates to a review on risk factors for transmission within long-term care settings and potential strategies that could reduce risk of reduce transmission in long-term care. So sort of two distinct questions in that same review. And so we updated, I think we did 3 or 4 updates to that rapid review. And then as vaccination was really becoming prevalent in long-term care settings, particularly in Canada, we realized that those risk factors for transmission or interventions were just going to look totally different in the context of vaccines. So we actually paused updates on that review. We did have another group approach us asking if we were going to update and how we would bring vaccines into it. And so that's something that we have not prioritized. So that group, I think, is pursuing a review, and we may have some collaboration sharing some of our synthesis and critical appraisal from our initial rounds of the rapid reviews. But that's so certainly if we were to continue updating that, we would be addressing a slightly different question, I think. Those risk factors around demographics and things like that, that predicted COVID-19 infection or mortality in long-term care settings is probably a little bit less relevant right now.
Great, and part 2 question is, when an existing review is available, do you fully trust that the review is including all of the relevant evidence up to that point, regardless of the quality of the synthesis?
Mm-hmm. Yeah, that's a great question. And this is something we've struggled with as well. We did a review sometime last fall, I think it was, Maureen, on an update to one we had done, one of the very first ones we had done on pregnancy, COVID-19 on pregnancy-related outcomes. And we found, by first looking at just the syntheses we had identified, I think we found something like 30 different syntheses. And when we started to just sort of at a high level informally map across those syntheses how much overlap there were in those single studies, unfortunately we found very little overlap. So that sort of brings up concern, and sometimes it makes sense in terms of slightly different inclusion exclusion criteria that are used by different teams in different jurisdictions, and of course sometimes it's the time period of the search date and things like that. So if we are just relying on that synthesis to move forward, we do try to, if there are multiple syntheses, try to look whether there's good coverage across those. But once first they have to identify a comprehensive search strategy. They have to include critical appraisal, and then we do critically appraise it using the AmStar tool to make sure that it's high quality. And then depending on the time period that we have and how much literature is available, we may make a decision to build upon that, or do a more comprehensive search, include that synthesis in our rapid review, but still include previous single studies if we feel like there may be some things that have been missed, either based on the just different eligibility criteria or just slightly different question that they're answering.
And we had a response from Simon from the first question, and that was a suggestion around using a time series perspective as a way to explore the evidence with the evolving nature in the pandemic, and also a suggestion around the use of meta-regression where time, vaccine rates, or country area case rates might be included.
That's a great suggestion. We have not done any meta-analyses within any of our rapid reviews. Certainly some type of meta-regression would kind of address this point. We have within our team not a ton of capacity for meta-analyses, so that would be a challenge to do within our team, and one of the reasons we haven't included meta-analyses, one, our in-house capacity, and two, just the extra time that it takes. But that would certainly be a way to get around that.
Great, and interesting comment here from Kaylin, which he's also just giving us a nice compliment about our living review on school transmission. His question is, so given what we know from this living rapid review that we've been updating for a year now, were we surprised when recommendations from data modelers, for example, the public statements of the 6 to 11% case growth, even when IPAC measures were in place, if school children had returned to in-person learning, are we surprised when it deviates from the bottom line of our reviews?
Mm-hmm.
And have we been engaged by these other evidence producers on such topics to square divergent results?
Yeah, that's a great question. And I just see the last piece is, do we think that it's a case of research having a hard time catching up with real-time analytics? So I think in terms of, for example, with schools and daycares, I think that we are concerned, particularly about the variance. We were constantly watching for new evidence that was coming out about how variants were potentially changing the transmission rates and impact on children and impact on school transmission. So that's one piece where we were really actively watching for that and searching specifically in places like Public Health England, where we knew the variants were taking over earlier there and their schools were still open at the time. And so can we, look to Public Health England? Are there any reports that are coming out, and really looking to doing some gradelet searching there to make sure that we're getting even aside, like on top of the evidence, scientific evidence published and preprint, are there any sort of reports? And there were some early reports from Australia that we had found and things like that. So that's one piece, is just making sure that things in real time we are catching up, because we know that researchers are slowing down a little bit, I think, in terms of how quickly they're getting some of these things out. In terms of the modeling pieces, that particular number, we did try to do some digging as to where that number came from and never could actually get a solid answer. So sometimes we do wonder why there is such difference when we look at, not only the evidence from around the world, but the evidence that what we see in Ontario in terms of the publicly available data that's released on the Ontario dashboard, for example, and then where some of the modeling data comes from. So we have, in that particular review, have never included modeling data, predictive modeling data that's not based on actual data, just pure predictive modeling. We have not included those studies in our review because we felt that we have enough evidence from real-time data collection that we don't need to include those. We have included some modeling data in other reviews that we've done, one on post-secondary transmission. One of the reasons also is that we don't have a great capacity in our team to properly appraise those studies, because they are really difficult to appraise. So we've been able to connect with another team at McMaster to help us to identify what are the high quality modeling studies and what are the lower quality ones, so that we can base our kind of key findings on the more high quality studies. But it is challenging when we hear some of these numbers being put forth, less so from the research, but more from the policy or politician standpoint, is where some of the data, where do these numbers come from? It may make more sense if we had a better understanding of what went into those.
Thanks, Erin. I'm just going to take us back to a few questions that were posted earlier in the presentation. So one of them is, how do we search for preprints? Do we use the Europe PMC or every separate server?
So we specifically search medRxiv as the one preprint server we search on its own, and then we do search through the WHO database on COVID-19 literature, which includes a number of other preprint servers as well.
And then another question is around DAISY. So do we assess DAISY's accuracy, or are there any related publications?
Maureen, you might have a better sense of if there are any publications. So it is, I wouldn't say that we would put entire confidence in that. As if I were doing a full systematic review, I don't think I would feel comfortable using DAISY as my second reviewer compared to in duplicate traditional systematic review. But in terms of a rapid review, where we know we do have to take those shortcuts, earlier on we were just doing single reviewer title and abstract screening. We've added in DAISY as that second level to sort of increase the rigor. Would I publish that in a full systematic review? Likely not, but it's one of the things that we can do in a very short period of time to try to catch any things that we might have missed. I'm not sure if there's any publications on the accuracy of that, Maureen. Would you know?
I'm not sure. We actually did some other work with Distiller, and we hope to write that up. So I think we might have a better sense of what publications in a few months from now as we work on that paper. But we worked with Distiller to determine whether or not we could train a computer to do our inclusion and exclusion for healthevidence.org, which is a repository of systematic reviews evaluating public health interventions. And we tested, we did substantial testing on probably 70 to 80,000 titles over 10 years of maintaining health evidence. And basically, we were able to train it to identify, like it's basically reduced our set by 70%. So on every given month, we get about 10,000 titles to search. And we are very confident now that in allowing Distiller to search through those results, they kick out about 70%. It kicks out about 70%, leaves the 30% for us. And we know from the extensive testing that we've done that we may be missing 1 to 2 or 3 max articles in a month. And for the time savings, that's actually around 15 to 20 hours of savings in time a month that we can then put into doing the rest of the work of critical appraisal and getting that evidence into the repository and out to those that need it. So we did enough work with Distiller to feel that, to have some level of confidence in this fast moving rapid reviews during COVID to use that DAISY function. Sarah, there's another question here, which is around grade. So the comment is, we really struggle to get people to use grade. The perception that it is unwieldy in emergencies still prevails. Do you have any examples of how adaptable it is? And they've seen the paper that was on grade that we're using that's for emergencies, but wondered if there are any other examples that we know of.
Yeah, great question. And that paper really was what's kind of kicked us over that we'd been talking about using grade, and then we read that paper, and that's really what motivated us to actually try it out and put it into practice. And I think, if I remember correctly, that they suggested in that paper that it took about 30 extra minutes of time on top of a rapid review, 30 minutes to 1 hour. And I think that probably is fairly consistent. Once we got the hang of it on our team, that's probably similar to us. So I don't know of any other sort of methods papers that discuss that. We do have a preprint that's under review right now that describes our process. So I can add that to the chat as well for those that are interested. It describes a little bit more about how we use it. And it's constantly evolving too, as I think when we should probably address when we get reviewer comments back, we didn't have any qualitative studies, so we've now added grade CERQUAL in, which again takes a little bit of a different approach. But yeah, I think our experience has been, it's of course a little bit of an adapted version of grade, because we're not doing a meta-analysis that you would see in many systematic reviews, but it really hasn't added a whole bunch of extra time once you're familiar with the process overall.
Great, thanks so much for all of those questions. I'll just take us through our last few slides. So for us, it's always very important for our funder, the Public Health Agency of Canada, for us to evaluate not only be able to quantify what we do, but with what impact. And so throughout this year of our work with the pandemic, we have been mindful to try to think about how can we demonstrate what impact we've had. And so there were a few things. We early on created a rapid evidence service that we've talked about. We've done in total now 64 full reviews or updates in the past year, and we use a variety of ways to disseminate those out to those who need to know about them. So we post them to our website. We created an email notification system so you can subscribe to be alerted whenever we post a new one. We are active on social media. We include information on our about the reviews on in our monthly newsletter, and we've also really been more active with McMaster's communication team, who connect with various media outlets, and that has led to a number of interviews, journal articles, or newspaper articles as we try to get that information out there. Next slide. And then just a little bit about the impact. It is being, these reviews are being accessed not just by those in Canada, but by many countries around the world. We have answered priority questions from WHO, Public Health Ontario, and public health units. We've collaborated, as I said, with Public Health England. We have our email subscribers in almost every province and territory. Our reviews are indexed in a number of the COVID databases, and Sarah's really been really active with those, with the media coverage, particularly with the schools and daycare, several times over the year, and has completed more than 30 interviews, whether that was radio, online, TV, various. So those were really new activities for us in terms of being interviewed live on TV about questions that also are quite, there's a lot of political interest in those as well. Next slide. And of course, all of this doesn't happen without some challenges, which, and all of this really has been evolving on the fly, and we've had to tweak regularly the methods because nothing has stayed constant with COVID. So again, balancing rigor with feasibility. So we really were not willing to not put out as rigorous products as possible, but also realizing that if it was never in the hands of the decision makers fast enough, that we would miss that opportunity to at least have this evidence considered in the decision-making process. So trying to figure out what steps, what shortcuts could we take in order to really be able to do these in the short time frame that we've done. Of course, we've wanted to really contribute to minimizing duplication, but as many of you will know, it's a full-time job just trying to stay aware of what everybody else is doing. And so we've tried to do our best, but of course we know that in some instances there were similar reviews happening at the same time. It has been really challenging to next statement of getting the info into the right hands at the right time in the right way. All these decision makers are so incredibly busy. What is the best way to alert them to this information? And so trying to figure out and testing different ways to do that. Being proactive versus reactive. So for really many months in the pandemic, really it was just trying to catch up with the next thing that was happening. But every once in a while we've tried to think what might be coming next. And a good example of that was thinking about parental, the considerations that parents think about for vaccinating their children. So we actually started work on that one several weeks ago in advance of, well, we didn't get to it right before the 12 to 17-year-olds could be vaccinated in Ontario, but it's definitely there before any of those under 12 are ready to be vaccinated. So really trying to think future thinking, and can we work on some of those before it's an emergency and it's needed tomorrow. As you've seen, when to consider evidence that's out of date and what we would do with that, we've had to figure that out. Trying to think of how useful is evidence from other jurisdictions to Canada? How does it apply? And then really that signal to noise ratio, the low quality evidence, how did we make sure that that was really represented in the certainty of the evidence. Next slide. So just in our wrap up here, our conclusions and implications. So the implementation of a strategy that resulted in rapidly coordinated efforts on a national scale, that was something that we were trying to do. We know that another piece we didn't talk about was we created a repository of rapid reviews that were either ongoing or completed, relevant for public health. So anyone could register those, and that was a way to really try to reduce duplication. And we know that many have come to look at what is happening, what reviews were being conducted, and in some instances, folks didn't progress with a review because they saw that someone either had already done it or was doing it, and other times learned that no one was doing it, so they went ahead. So trying to really reduce duplication, the continuous evolving of the methods, trying to keep up to date with what others were doing with methods, while also trying to be explicit about our own, and really thinking about where to next for us. We've learned a tremendous amount about doing this work and working with policymakers, and so we're really hoping to be able to support others who maybe post-COVID may be working in this space around rapid reviews or evidence syntheses. I think that was really our last slide, just a little bit about our team. This is our small but mighty team that's been working on this. Okay, so I'm just seeing here, and we have, I guess we are at time. Just taking a quick look if there's anything really pressing for questions. There are some calls to action here about bringing folks together, different groups that would maybe able to work more collaboratively, and certainly we've been working with a small group of public health organizations who are providing reviews for their country to see if there's some coordination and consensus around methods that we might be able to come to agree on. Last question, do you see a lasting legacy of these reviews methods as providing ongoing evidence to public health policy decision making? I mean, certainly my sense is that we're not going back to months and years for a synthesis for policymakers, and certainly it's been really exciting to have this level of interest and demand for evidence syntheses, and I think there's a call to action for those of us who are doing this work to figure out what will be needed in order to be able to provide more rapid evidence syntheses that is still rigorous when even post COVID. So I think there's a lot of work already ongoing, and there's much more to be figured out. Okay, so I think we should, that takes us to 2 minutes past time. My apologies. We'll just like to thank everyone for your for attending today, for your fantastic questions and comments. Thanks so much to you, Sarah, for your presentation, and Steve for coordinating today. So thanks so much, everyone. Bye-bye.
Thanks, Maureen. Thanks, Sarah. And thanks again, everybody, for joining. I just wanted to mention before everybody leaves that recording from this webinar will be posted on the Covetent site, and we'll share it through Twitter in a couple of days when it's ready. So feel free to share that with your colleagues, and hope that this information will be shared more broadly as well, because it was a really great presentation. So thanks again, Maureen. Thanks again, Sarah. And thanks again, everybody, for joining us today.
Thanks, everyone. Thanks, Steve.